Great. Welcome back, everyone, to the House Healthcare Committee. We are now going to take up COVID flexibility language that we started last week. So we are looking at draft 2.2 under Jen Carby's name on the committee page for those who are following along. And we first have with us Devin Green from VAHHS, who's going to hopefully clarify some things we had started talking about last week. So if you can just set the stage for each one, and then we'll go from there.
Happy to do it. And so Devin Green from the Vermont Association of Hospitals and Health Systems. Again, just want to thank you for the work that you've done on this. I really appreciate it. I know that it feels like COVID is over, but I think the best analogy I can use, or the best story I can use to illustrate this, is we had one hospital member say, we have a committee that's incident command, but we can't call it incident command anymore because we meet every day. Like, we continue to meet, and incident command is supposed to be for a temporary amount of time. So we continue to have capacity struggles. Yesterday, 12 hospitals were reporting elevated or higher medical surge indicators. We had 5 ICU beds available.
So you only had 5.
Correct.
Statewide. And can you had sent me, and if you don't have it, I can do it, the COVID numbers?
Yeah, so the COVID numbers are, for yesterday, it was 42 confirmed COVID cases and 3 were in the ICU.
So 42 in the hospitals.
Correct.
Okay. 3 in ICU.
3 in the ICU. And I gave a little bit of context. Again, these numbers change. This is just point in time. Last year on the same date, there were 52 COVID cases. So 42 yesterday, 52 last year.
In the hospital.
In the hospital, not across the state.
Exactly. I want to make sure we're clear about that.
And 15 in the ICU. The year previously, in 2021, on yesterday's date, there were 37 COVID cases in the hospital and 12 in the ICU.
How many?
12 in the ICU, but 37 compared with the 42 cases yesterday. And, you know, it still has an impact on things like nursing home procedure and bed availability and all of those sorts of things.
So I'm just wondering, you're worried about the amount of beds you had. Did you say 3 only? Or
5.
5, okay. What's good? What would you not be worried about? What would you like to see?
Oh, how many open ICU beds?
An ICU beds. Yeah, it's really concerning when you're in single digit beds across the state, because you want to have our hospital system is our emergency management and response system as well. And you want to have some capacity to bring in people quickly. So typically we want to be at 85% capacity.
Which is how many beds?
Total in the system.
Well, I mean, since you're using 5.
Yeah, 5 total.
So what's good? I'm just trying to.
I mean, for ICU beds, right, you probably want, I remember during COVID, people getting concerned when we would get into single digit beds. And I think it is a concern because if you have a major catastrophic event, where are people going to go? I can look back and get more data on where we are typically. I think we always run pretty close to capacity as it is.
That's what I'm curious about exactly. So, you know, how big a problem is it currently, or how big is the problem overall?
Yeah. Yeah, so it's still a problem.
I mean, it's effort,
but I just wanted to get a context.
Yeah, I will say earlier this week, EVMMC has, you know, they are licensed for 400 beds. They had 450 patients. So.
Which is not all COVID related, but.
No, not COVID related.
They're still up. There are still people in the hospital with COVID. There are still people in ICU with COVID, and there are still deaths from COVID.
Yeah. I think the other point is we are still, you know, the worry from COVID was our hospital system would get overwhelmed. And that was what a lot of this work was trying to get at. And I think my point is our hospital system is still at that close to overwhelmed stage. And so it makes sense to keep these in place.
Are those people that are in the hospital, in the ICU, are they older people?
I don't know. I don't know who that patient population is.
Last time I looked at that, there were predominantly older people.
Yeah, it's possible. It could be people after an operation.
No, I mean with COVID.
Oh, with COVID, the 3 people in the ICU with COVID. Yeah, I'm not sure what their ages are.
Okay. All right, so let's go to your first, which section do you want to start with?
Sure. So I'll start with section 5.
So we do a page, are you
Yeah,
looking at the draft?
section 5 on page 3 at the bottom half.
Section 3.
Section 5, page 3.
Where it says proposed language coming soon, and unfortunately I don't have, so, instead we are just gonna go with Jen's language.
Okay, so can we say what this section is?
Yes, so this section was, with the Green Mountain Care Board, we were asking for flexibilities, pertaining to COVID on regulatory things like the certificate of need process in case we needed to make any building changes quickly in response, or things like the hospital budget process. Also included here is the health insurance rate review and the ACO budget review. The Green Mountain Care Board has used this in a couple of instances. I think the healthcare advocate testified that, you know, they've used it judiciously, and they are comfortable with expanding this for another year, and we are as well.
Okay, so to be clear, we are not changing what has been in statute. We are simply extending it for 1 year. And we heard from Green Mountain Care Board that they were okay with this as well during testimony. So we'll just take out the language that's highlighted in yellow.
Yeah.
Okay, what's next?
And then we'll go all the way to section 17, which is on page 6.
Okay,
And there are 2 concepts that we want to talk about here, and Jen can walk you through the language a little bit more if needed. The first concept is in the telehealth piece. So right now, with telehealth, there's a registration system that is supposed to end June 30th, and then there will be a new framework put into place in July. We are concerned as providers that if the new framework is not ready, there will be a gap. So we have suggested just extending it until the new framework is in place, so there is no gap. And OPR and the Board of Medical Practice agreed to that.
any questions on that? So we don't have the language yet in front of us. Jen will walk through that, but basically.
I will be drafting it.
You
Unless
will-
you talk a little while.
I could, well, yeah, okay.
Because I will work on it.
Okay.
I already drafted the other piece.
Okay.
So,
So let's just stick to this. Any questions on this piece? So we're simply extending what's in place today until the new licensure process for telehealth, which this committee started with last session, will be in place.
Well, I agree with it. It really isn't a COVID thing, is it? Is it?
It is,
How is it wrapped around COVID, I guess? Yeah.
I think it's wrapped around COVID in terms of, what it's done is there's been an increase in telehealth due to COVID. And I think it has allowed providers to provide care more safely, and have less COVID contact. There are still people who get COVID and call in their provider and have a telehealth appointment for their Paxlovid prescription or that sort of thing. So I think it's helpful there. And then I think it's also helpful in the mental health piece. You know, that's sort of second tier to COVID, but it is something that has come out of it.
And so if we let this lapse on March 31st, correct me if I'm wrong, Devin, people who want to practice telehealth and haven't completed the registration process, there'd be a lapse of timing. How does that work?
Potentially, there would be a lapse of timing. So I think the registration process is set in place until June 30th. But again, everyone is having workforce challenges right now. So if come June 30th, if that framework is not put into place, it could cause all sorts of chaos in terms of licensure and billing and how that would work for patients, if there's 2 weeks in between or a couple months. So we just want to make sure there's a seamless transition into that new framework.
Okay.
And then the next piece is also in section 17 and section 17F.
So do you have sorry, I just want to make sure we're all there. Page and line number.
Yes, page 8, bottom of page 8, all highlighted.
Row 17, highlighted in yellow. Okay.
Yes.
So this, and our apologies for this, I think this got a little confused. And my thanks to the payers and DIVA, the commercial insurers, MVP, Blue Cross Blue Shield, and DIVA for coming together on this quickly. But what we were trying to do here is we had heard from people that there were some payers who were not really considering the deemed licensure a Vermont license for purposes of the accreditation process. So they sort of, it was just, they would stop at that point. They would say, oh, this is a deemed license, never mind, we're not enrolling you. And we don't want the accreditation to stop at that point. We want you to be able to actually implement this flexibility and have it used in the way it's meant to be used, which is this is considered a Vermont license, and then you can do the rest of your credentialing from there. So the new language that we're adding is, it's the same as it's here in F. And then after enrollment, we're putting, but this does not change other credentialing requirements.
And we'll see that from Jen at some point.
Yes, it's a little wordier.
It's a little wordier.
Oh, okay. That's the concept.
That's the well, actually, you might be a lawyer, so I
am a lawyer.
I shouldn't say that that's a non-lawyer response.
It's the like forensic lawyer.
And that, I'm gonna look over at Jessica, that is all we have.
So this, I know, was a big discussion last week, and I have to admit I was thoroughly confused. So are there questions on this section? Again, we'll walk through it with Jen and the actual language, but the intent of what we're trying to do. Okay,
All right.
thank you.
Thank you.
Ginger, are you testifying or?
See if Ashley is going.
Okay, great. Come on up. And Ashley's on, there she is.
There she is.
Welcome.
Sue Ellen Batigi, Director of Member and Provider Services at the.
I'm sorry, your first name again?
Sue Ellen,
Sue Ellen. Great, thank you.
Department of Vermont Health Access. I am just going to talk, I'm going to follow Devin in the last article, page 8, line 17, on the healthcare licensure for deemed licenses. DIVA has no concerns on this at all. We would like, after Medicaid, may consider instead of shall consider, but that is our only change. I think we've all come to understanding on what deemed licenses mean. And we've made ourselves available both to Devin and Jessa if there's any problems with providers enrolling with Medicaid.
So I think changing from shall to may is a pretty big change. So I think we had this discussion earlier. I'll just say it again. Shall, you must do it. May, you could do it if you want to.
Okay.
You don't have to. So before you leave your seat, I would love comments from.
Yeah, I think, so my only, and then Jessica can speak up too. I think my only concern is there are other commercial insurers beyond our friendly local commercial insurers that I would like this to apply to. And I worry that they would just totally ignore this flexibility if shall is not in there.
Yeah, thank you. Jessa Barnard with the Vermont Medical Society. That's our concern, is that this has been, even the language we're trying to put in here around F about accepting a deemed license for the purposes of credentialing has been part of the what may be part of flexibilities from the beginning. And some payers have been doing that consistently already and others have not. So our concern is having it be a may allows that to continue to be flexible and inconsistent when the intent is really, this is a Vermont license. However you got this license, the licensing entities, OPR and Board of Medical Practice, are considering this a full license to practice in the state. So the payers should accept it in the same way. So I think that is a pretty big difference for us from the
Ultimate.
Ultimate.
And I'm coming back to you in a second. Sarah, did you want to comment on this at all?
I'll just say really quickly that Blue Cross
Can
is
you-
all.
Can you introduce yourself?
Sorry.
Sarah.
Sarah Teach out from Blue Cross and Blue Shield of Vermont. We are already accepting a deemed license for purposes of credentialing. So we just like the clarification that it doesn't impact any of the other aspects. So
Okay. So the additional language that Jen's working on. Thank you.
I saw Jen's language. It looks great.
Okay, great. So back to DIVA and shall versus may. So can you explain why you would want it to go to may and how that impacts Medicaid's credentialing process?
Certainly. It doesn't. So we already accept deemed licenses. I want to be clear about that. We already take the deemed licenses. Our concern is that healthcare providers may read this and determine no matter what is on the deemed license, whether it's a sanction or anything like that, that we have to enroll them if it's the word shall. Well, we're still looking at what is on the license. So we don't want any misconceptions, although we'll look at the deemed license. We still have all of our flexibilities with enrollment.
Right, so this is, can I ask you a question? So does the language you're adding at the end get to that concern?
Same concern about it not affecting anything else about the
Credentialing process.
credentialing process? I believe so. So what I have.
Can you introduce yourself?
Oh, sorry. Jen Carvey, Legislative Counsel. So at the end of the language that we had looked at the other day about deemed licensure being considered sufficient to meet applicable Vermont licensure standards for purposes of credentialing and enrollment, I added, provided, however, that this deemed satisfaction of the licensure, certification, and registration requirements shall have no impact on any other credentialing or enrollment requirement.
Everyone's shaking their head, yes. All right.
We can live with it.
Okay, great. Any other comments on any of the other sections?
No, that was the only one I was speaking on. Ashley gets everything else.
Okay, great.
Thank you.
Hi, Ashley.
Hi, I think I can be Ashley Berliner, Director of Medicaid Policy, Department of Vermont Health Access. And I think I can be really quick here. The section that I'm going to be speaking to is section 26, which refers to telemedicine and HIPAA.
So hold on, Ashley.
Requirement.
Sorry, Ashley, hold on. So now we're on page 9. Is that where the HIPAA is? Hold on. Yes, so page 9, I believe at the bottom, right, Ashley? You may not have it. So I think it's number 2. 1 and 2.
1 and 2, yes.
Yes.
So we're fine with this language as it says that it has to be permitted by federal law, but just wanted to indicate that we have no reason to believe at this time that waiving HIPAA provisions will be extended beyond the public health emergency, which is slated to end on May 11th. So wanted to just make sure that the committee understood that we're adhering to this to the extent that we can under federal law, and we believe that that permission will expire at the end of the PHE.
Jessa Varner from the Vermont Medical Society, just to chime in that we agree with that assessment. I think the reason we were suggesting extending the date for a time certain rather than the federal public health emergency is just because for consistency with the other sections, and that by being consistent with federal law, we agree that is likely to end in May when the federal public health emergency ends. But that just gives the flexibility in case there's any change in that status.
Thank you. And the language is okay for that purpose?
Yes, I think the language is okay for that purpose because it says, to the extent that waiver is permitted by federal law or guidance regarding enforcement discretion, and this really sets that flexibility, allows that flexibility to the extent that it's allowed under federal law until next March, should there be a reason that that flexibility returns at the federal level after the end of the public health emergency and before you have an opportunity to revisit in legislation. Otherwise, our statutes are tied, our statutes require HIPAA compliant connection. So
Okay.
this is saying we're suspending the Vermont requirement as long as it's allowed under the federal requirements.
Okay.
So I think you have heard the expectation that the public health emergency will truly be over and that flexibility on the date Ashley mentioned.
Okay, May 11th.
But so I think as long as there's sufficient communication to providers, so they're not expecting some additional flexibility that won't be available after that, I don't think having it in effect longer is well legally.
Right. Ashley, anything else for Medicaid?
That's it.
That's it. Okay, so thank you. We're gonna give Jen some time to finish the language.
Just need another minute to finish my thought.
Okay, so we're gonna let her finish her thought. In the meantime, hopefully that all made sense. So we're gonna walk through the language again with Jen on the areas where there's changes. We will have Human Services provide their input on their sections next week. So now the question is in front of us about moving this forward. We won't take a vote today, but are there comments in general about this bill?
It's, I have one, is there any money attached to this thing?
There is no money attached to this thing. Nope.
And there's no taxes or anything
There's
else? that has to
no
be- So it has
taxes.
nothing to do with Ways and Means?
Nope.
Okay.
This is simply ours. Again, it's generally an extension of some of the COVID flexibilities that we have put in place over the last couple of years. All right,
This might sound stupid, but
nothing sounds,
can we purge some of the COVID language out of this? Just because it seems like a lot of it is just something, not just something good to do, but being done around workforce, around procedure, around things. Then the reason I ask is because the federal thing is going to go. We've heard that no other state has this type of thing. And it seems to me that maybe the perception of it would be better if COVID was kind of honed out of it. Just a thought.
so I appreciate that. And I think some of the workforce things that are in here that could help us long-term should come before us in a separate request potentially, that we make some things permanent if healthcare folks think things should become permanent.
Yeah.
But we're not ready, we're not at that point yet.
No, I know we're not, but
But the point of doing this right now has always been around the flexibilities that we feel are needed in order to still tackle COVID, which is still affecting our
I think
hospitals.
a year from now, it'll be any different. I mean, we just heard the numbers are pretty consistent year to year. I just think that this is, I don't know if you want to call it a permanent thing, but it's relatively long-term. So I just feel like we're just extending something maybe that either you make it permanent or you do something different than just continuing this. I don't know.
Yeah, and I totally hear you. And I think, sometimes our role is, and what our role really has been the last couple of years with this is helping our health system with what they need to ensure they are able to serve Vermonters to the best of their ability, which has been really, really stretched I will say, I would really hope that if this is before us again next year, it is to talk about what needs to be made permanent,
Yeah.
if anything.
I would hope so.
Yeah.
Because this is now going beyond the federal thing, so, yeah.
Anyone else? All right, so we can take